imagine you are sitting in a clinic room, you're reviewing a patient, and it is exactly 12 weeks after you started them on a mucosal treatment plan. They're sitting right across from you, and they report like zero subjective improvement.
None at all.
Right, like no change in their mucosal hydration and absolutely no reduction in their pain. The expectation of a clean, engineering-like fix is just gone.
Yeah.
So where do you go from here?
Well, I mean, it's a moment literally every clinician dreads. You expect things to be straightforward. You apply a treatment, the tissue heals, the patient feels better.
Yeah, that's the dream.
Right. But in the realm of mucosal health,
Uh-huh.
when that timeline stretches out to 12 weeks with no response at all, you have officially entered diagnostic muddy waters.
Mm-hmm.
The instinct is often to just push harder with the exact same approach, to double down on that initial prescription.
He just wanted to work.
Exactly.
Yeah.
But the analytical reality is that we must look at the bigger picture here.
Okay.
We have to question our baseline assumptions, rely strictly on evidence-based step-up therapies, and really resist the urge to just guess.
Yeah, you expect a clean fix, but today we're diving into a stack of clinical guidelines and pharmacological data to solve this exact medical cold case. So our mission for this deep dive is to decode the puzzle of the 12-week clinical non-responder.
It's a huge challenge.
It is, and I find this incredibly fascinating because we are looking at all these different areas like the mouth, the eyes, the bladder, the reproductive tract, and they all share this incredibly vulnerable mucosal lining,
Yeah, they do.
So before we even talk about escalating to heavy-duty medications, the very first step in managing a non-responder has to be, well, questioning that baseline assumption. I mean, if the treatment isn't working, maybe the diagnosis itself is just incomplete. It's kind of like a check engine light on your car, right? If you add oil and the engine is still knocking 12 weeks later, you don't just keep pouring in more oil.
No, you'd ruin the car.
Right. You check the transmission.
And the clinical guidelines for conditions like interstitial cystitis or bladder pain syndrome, they take that exact approach. The sources specifically state that the failure of multiple modalities of therapy suggests a possible misdiagnosis.
Oh, wow.
Yeah. You have to be willing to ask if you're even targeting the correct pathology in the first place.
Which, that brings up genitourinary syndrome of menopause, right? GSM.
Yes, absolutely.
The guidelines note that if a patient fails their primary treatment for GSM, the immediate recommendation is a repeat physical exam and possibly a vulvar biopsy.
Or a referral to a specialist, yeah.
Right, a specialist, because we cannot just assume every intimate symptom is a standard part of menopause or like a stubborn yeast infection or just some cosmetic problem.
No, you really can't. Connecting the symptoms to the actual underlying biology is just non-negotiable here. I mean, if a patient presents with new bleeding or ulcers that aren't responding to standard estrogen therapy.
For localized moisturizers and stuff.
Right. If they don't respond, writing it off as just stubborn GSM is a massive risk. Those tissues have to be assessed promptly because you could be missing a dermatological condition, an autoimmune flare, or even something malignant.
That is terrifying. So if GSM and bladder pain require us to really double check for structural damage, what do we do when there's no structural damage at all?
Well, that's where it gets tricky.
Because I'm looking at the data on burning mouth syndrome, and it seems like the ultimate trap for a clinician. I mean, imagine a patient complaining of severe, constant oral burning. I say it feels like they just drank scalding coffee.
Awful.
But when you look inside their mouth, the mucosa looks completely normal. Like, there are no visible signs of tissue damage whatsoever.
Yeah, and that visual disconnect is precisely why burning mouth syndrome, or BMS, is so often mismanaged. BMS is a diagnosis of exclusion.
Meaning you have to rule everything else out first.
Exactly. You cannot just look at it and know. You have to run blood tests, saliva tests, allergy tests to rule out infections, local irritants, or even nutritional deficiencies.
Oh, I see.
And if all of those come back clear and the severe pain is still there, you are likely dealing with primary BMS.
Which means if a clinician just assumes the patient has a dry mouth and prescribes like a basic moisturizing spray, it's going to fail completely, right?
Oh, it will fail because primary BMS is neuropathic. It's a nerve signaling issue. It is not a moisture deficit issue. Treating a neuropathic condition with a water-based mouth spray just misses the mechanism entirely.
Because the water doesn't do anything for the nerves.
Right. To actually manage it, you have to target the nerves themselves. The guidelines point to medications like anticonvulsants or clonazepam, which work by calming those overactive pain pathways rather than just, wetting the surface of the mouth.
Okay, so BMS is essentially a hardware issue with the nerves. But what do we do when the hardware is fine and the physical environment, like the moisture itself, is actually the problem?
Good question.
Let's say we've verified the diagnosis, the check engine light was right. The next logical step is to examine the specific tool being used to treat it right.
Yes, exactly.
We need to look at whether the treatment is physically capable of sustained relief or if it's just a temporary band-aid. And this brings up the massive difference between aqueous or water-based barriers and lipid-based barriers.
Yeah, and this distinction basically dictates the entire trajectory of mucosal therapy. Take dry mouth, for instance, or xerostomia. Traditional saliva substitutes are water-based.
Right.
They might provide a soothing sensation for a few minutes, but they wash away incredibly quickly. But worse than that, frequent water rinsing can actually strip the oral mucosa of its residual salivary proteins and mucins.
Wait, really? So it's actively making the patient's biological defense weaker?
Over time, yes. It removes the natural biological protective layer, which ends up exacerbating the dryness and the friction in the mouth.
Wow.
This is where the pharmacological shift to oxidized glycerol esters, or OGT, becomes so necessary. This is the technology used in prescription lipid-based sprays, like a Quarrel.
Okay, walk us through how OGT actually changes the environment on a cellular level. Like, what is it doing?
Sure. So instead of just adding temporary water, OGT forms a durable, lipid-based film that adheres directly to the oral mucosa.
Like a seal.
Think of it exactly like an artificial seal. It acts as a physical barrier that lowers transepithelial water loss. Essentially, it locks the existing moisture inside the tissue.
Oh, that makes sense.
And because it is a lipid, it doesn't dissolve and wash away instantly like water does. It can last 4 to 6 hours, providing sustained mucosal defense and basically allowing the underlying tissue time to actually recover.
Okay, but wait. If these lipid sprays act like a durable shield that lasts for hours and they don't strip away the natural proteins, why are we torturing patients with water-based stuff that washes away in 5 minutes in the first place? I mean, is it just a cost thing?
Well, cost, accessibility, and really the foundational logic of a step care approach.
Okay.
Guidelines generally prioritize the least invasive and most widely accessible options first. We see this exact same logic applied in the eye, specifically in the TFOS DWS2 algorithm for dry eye disease.
Oh, let me translate that acronym real quick for you. That's the standard stepwise clinical guideline for treating dry eyes. Right?
Correct. So in step 1 of that algorithm, you start with foundational measures. That means standard ocular lubricants, patient education, environmental changes.
Just the basics.
Just the basics. But if the patient is a 12-week non-responder and they are still suffering, the algorithm dictates that you immediately move to step 2.
And what's step 2?
If meibomian gland dysfunction is present, meaning the eye's natural oil production is failing, step 2 introduces lipid-containing supplements to replace that missing oil layer. It also strongly emphasizes moving to non-preserved lubricants.
Ah, because the preservatives in the standard eye drops start causing their own damage, right?
Yes, exactly. Preservative-induced toxicity on the surface of the eye is a very real problem when patients are using these drops multiple times a day.
That sounds miserable.
It is. You have to step up the complexity of the physical barrier to match the severity of the tissue compromise while removing anything that could irritate it further.
So, lingering on step 1 is the real mistake here. Transitioning to a localized, lipid-based prescription or a preservative-free option is the necessary pivot.
Absolutely.
But what happens if we do that, and the tissue actually does start to heal, but the patient still feels terrible? Like, we really need to unpack the disconnect between objective healing and subjective symptom reporting.
Yeah, this is arguably the most challenging phase of treating chronic mucosal conditions. You have to separate what the patient reports, their subjective experience, from what the tissue actually shows, the objective biological data.
It's like when you break your leg.
Yeah.
6 weeks later, the x-ray might show the bone is perfectly knit back together. Objectively, the fracture is completely healed. But when you try to put your weight on it and walk, it still hurts like crazy. The subjective experience is just lagging completely behind the biological reality.
That is a perfect analogy. And that phenomenon is heavily documented in mucosal tissue recovery. If we look at the sources on ulcerative colitis or UC, we see how critical this is. In treating UC, clinicians cannot just treat to the endpoint of how you feel. They use what is called a treat-to-target approach.
Meaning they aim for a specific measurable score rather than just getting a thumbs up from the patient.
Exactly. The primary goal is a Mayo endoscopic score, or MES, of 0.
Okay, 0.
That signifies complete mucosal healing on a colonoscopy. Here's the trap. If a patient achieves an MES of 1, they might report feeling completely fine. Subjectively, they believe they are in remission and want to stop or reduce treatment.
Oh, I see where this is going.
But objectively, that MES of 1 means they actually have a threefold increased risk of clinical relapse compared to a patient with a score of 0.
A threefold risk. Wow. So if you just trust their subjective symptom report that they feel fine, you are basically leaving them completely vulnerable to a massive flare-up down the road.
Yep. And the reverse is true for our 12-week non-responder. They might feel awful, but the tissue might actually be improving. To get that objective data, clinicians must rely on specific tracking scales rather than just asking the patient if it still hurts.
Let's ground this a bit. What do these tracking scales actually look like in practice?
Well, for oral dryness, clinicians use the Chalicombe scale. It assigns points for highly specific objective visual signs. So the clinician is looking for things like, is the dental mirror sticking to the buccal mucosa? Is the saliva visibly frothy?
Earthy saliva.
Okay, or is there a glassy appearance to the palate, indicating a complete lack of moisture?
I love that. It takes all the guesswork out of it. You aren't asking, does your mouth feel dry? You are literally just looking for a glassy palate.
It creates a standardized baseline, which is huge. In genitourinary syndrome of menopause, we see similar objective tools. The vaginal health index assesses elasticity, fluid secretion, pH levels.
Nice and measurable.
But even more microscopic is the vaginal maturation index, or VMI.
Oh, the VMI is fascinating. It's basically a cellular census, isn't it?
It really is.
Yeah.
The VMI involves looking at the cells scraped from the vaginal wall under a microscope to see if there is a shift away from parabasal cells. A dominance of parabasal cells is an objective marker of severe estrogen deprivation.
Okay, so what's the goal then?
The biological goal of the treatment is to shift that cell population towards superficial cells.
Hold on, let me make sure I'm picturing this right for everyone. Are we basically looking to see if the tissue has graduated from immature, struggling cells to fully functioning, mature ones?
That is the exact biological mechanism. Parabasal cells are essentially the immature foundational cells. When estrogen is present and the tissue is healthy, those cells mature into superficial cells.
Got it.
So if the VMI shows that shift is happening, it proves the tissue is actively absorbing and responding to the estrogen therapy, regardless of how the patient feels in that specific moment.
What stands out to you as the listener here? Because for me, it's the realization that patient-reported symptoms are only half the story. If your objective scores, like the VMI shifting to superficial cells or the Chalicombe scale improving, if they are getting better, but the patient is still sitting across from you in pain, you are succeeding biologically, but you're failing symptomatically.
And realizing that divergence is really the threshold to the next step. If the biology is healing, but the pain remains, you must escalate pain management. But, and this is a big but, you have to do it strictly through evidence-based pathways, because this is the point in the timeline where desperate decisions are often made.
Right, because when a patient is in sheer agony after 12 weeks, desperation sets in, both for the patient who just wants relief and the clinician who desperately wants to fix it.
Exactly.
Let's talk about how to escalate safely, starting with oral mucositis. This is the severe mucosal breakdown that's common after head and neck radiation, right?
Yeah. The pain from oral mucositis can be so severe that patients just stop eating and drinking entirely, leading to severe dehydration and hospitalization. The traditional go-to for decades has been magic mouthwash.
Which is usually like a compounded mix of lidocaine for numbing, diphenhydramine, and an antacid to help it coat the mouth. It's incredibly common.
It is common because it is accessible, but the clinical evidence actually tells a different story about its efficacy. Studies show that a topical morphine 0.2% mouth rinse actually results in a shorter duration of severe pain compared to magic mouthwash.
A morphine mouthwash.
Wow. Furthermore, the localized morphine significantly reduces the need for the patient to take systemic analgesics like oral narcotics, and those come with their own huge host of side effects.
So the evidence-based escalation is actually localized morphine over a standard numbing cocktail. That's a huge paradigm shift. What about escalating for severe bladder pain in a non-responder with ICBPS?
For bladder pain, the step-up involves bladder installations, where medication is placed directly into the bladder via a catheter. You can use 2% lidocaine to numb the mucosa. But here is the crucial biological detail. To make it effective, you must alkalize the lidocaine by adding 8.4% sodium bicarbonate.
I have to marvel at the sheer specificity of that. Alkalizing it with sodium bicarb. Why does changing the pH of the solution matter so much for pain relief?
It all comes down to the chemistry of ionization. In an acidic environment, lidocaine is ionized, meaning it carries an electrical charge.
Okay, so it's charged.
Right. And charged molecules have a very hard time crossing the lipid bilayer of cell membranes.
Ah,
By alkalizing the solution with sodium bicarbonate, you increase the amount of non-ionized lidocaine. This non-charged version easily penetrates the bladder mucosa. It physically absorbs into the tissue much faster and more thoroughly, which provides rapid relief for a severe flare.
that is incredible. Just tweaking the pH dictates whether the drug actually gets into the tissue or just sits on top of it doing nothing. And the sources also mention instilling hyaluronic acid like cystostat or ialuril directly into the bladder as well.
Yes, the goal there is replenishing the barrier from the inside out. It helps rebuild that protective glycosaminoglycan, or G layer, that lines the bladder.
It's easy to say, stick to the evidence-based pathways. But when a patient is crying in your office after 12 weeks of no progress, I can totally see why a clinician might want to throw an off-label Hail Mary just to offer some hope.
It's totally understandable.
How do the guidelines address that desperation, especially in areas like dyspareunia or unexplained pelvic pain?
Well, it requires extreme clinical discipline to avoid shiny object syndrome. The urge to try anything is strong, but the sources explicitly reveal the danger of uncertainty here.
Yeah.
There are many interventions that simply lack consistent evidence over a placebo.
Like using botulinum toxin A Botox for provoked vestibulodynia or prescribing off-label gabapentin for chronic pelvic pain without a defined pathology?
Exactly. Neither of these has shown consistent benefit over a placebo in randomized trials for those specific mucosal pain conditions. Deviating into investigational treatments without a solid evidence base can waste crucial time, give the patient false hope, and potentially introduce new systemic side effects that complicate the clinical picture even further.
It's wild to think that solving this 12-week puzzle requires completely shifting our mindset at every stage. We started by questioning the actual diagnosis to make sure the check engine light wasn't warning us about the wrong part.
Right.
Then we swapped out temporary water-based treatments for durable lipid barriers that actually seal the tissue. And finally, we realized that just because a lab test or a cellular census says a patient is technically healing, it doesn't mean they aren't still in agony, which requires highly specific, localized pain escalation.
It is a rigorous, very analytical roadmap, but before we close this out, there's one detail hidden in these sources that really reframes everything we've just talked about.
Oh.
Yeah. We're looking at the mouth, the bladder, the gut, and the reproductive tract as isolated problems. But the data points to a paradigm shift, the mouth-uterus connection.
The mouth-uterus connection. Okay, you have my full attention. What does that actually mean?
So all mucosal tissues in the human body share systemic, immune, and circulatory pathways. From the gums to the gastrointestinal tract to the vaginal mucosa, they're not isolated anatomical islands. They are part of a continuous, interconnected biological network.
Wait, so a vulnerability in one could actually signal a vulnerability in the whole system?
Yes, this raises an important question for you to ponder. If a patient is completely refractory, completely unresponsive to localized treatments in one specific area for 12 weeks, could it be that we are trying to treat a localized symptom of a much larger systemic mucosal vulnerability?
Oh, wow.
Think about it. If the mouth is severely compromised, is the gut lining also compromised? If the vaginal mucosa is failing to heal despite localized estrogen and lipid barriers, are there systemic nutritional deficits like essential fatty acids or vitamins A and C that are preventing epithelial repair globally?
That completely changes the frame. You aren't just treating a dry mouth or a painful bladder anymore. You might be looking at a systemic failure of the body's mucous membranes.
Exactly. It forces us to look beyond the isolated symptom, to realize that the 12-week non-responder might not just need a different localized spray, but a comprehensive evaluation of their entire interconnected mucosal system.
Think back to that clinic room we started in. It's been 12 weeks. The patient is sitting across from you, they still hurt, and they are looking to you for answers. The expectation of a quick, binary fix is definitely gone.
Long gone.
But now, you don't just stare blankly at a treatment plan that isn't working. You have the objective scales, the chemistry of lipid barriers and alkalized painkillers, and the evidence-based roadmap to finally decode their pain.
You are no longer guessing. You are investigating.
And that is how you crack the case.